Morning, everyone. Thanks so much for joining us. I hope you're enjoying this so far. I know I've learned a lot this morning already, and there's always more to learn when it comes to MS. That's one thing I like about working in this field is we're always expanding and growing and learning more. So I'm excited to talk to you about spasticity today. My name's Paige Sutton. I'm an MS specialist at Ohio Health, the newest member of the team. I joined in August of last year. After doing my residency at the University of Kentucky and fellowship at Duke University, where I spent some time learning more about spasticity and doing botulinum toxin injections for spasticity, which we'll also talk about today. So first, I want to make sure everyone understands what spasticity is before we talk about how to treat it. So spasticity, you can basically think of as a muscle being tight. So it's tight when you don't want it to be. You're not telling the muscle to be tight, but your muscle is in a tight position or it's intermittently causing spasms. And so that can be painful. It can also cause trouble moving that part of the body, either the limb or the trunk. You can see in these examples here on the left, this patient has spasticity in their arm that's causing their elbow to stay flexed, and also their wrists to stay flexed and fingers to stay flexed. So right next to it, you can see some of the muscles that might be involved in that spasticity. So sometimes it's a single muscle, a lot of times it's a group of muscles that are involved. So what causes spasticity? It's caused by damage to the brain or spinal cord. So some part of the central nervous system is affected. And that can be for a lot of different reasons. So we're talking about MS today, but also similar conditions that are autoimmune can cause problems with spasticity. Stroke is a common one that we see in our spasticity clinic. And then traumatic injuries to brain and spinal cord can also cause spasticity. So basically the signaling pathway from the brain down the spinal cord to the nerves to the muscles is getting messed up by some damage to brain or spinal cord. And so that muscle is overactive and tight when it shouldn't be. And this is not a comprehensive list, but a lot of the common causes of spasticity here. When it comes to diagnosing someone with spasticity, there's not tests that we use or imaging that tells us that someone has spasticity. It's really about the history, what the patient is telling us. So we're going to ask about mobility and functioning of arms and legs. We're going to ask about pain and muscle spasms, which are intermittent contractions of the muscles that cause pain and discomfort. And then on examination, we're going to look at a lot of different things. So tone, meaning the resistance to us moving that joint and muscle. Looking at the deep tendon reflexes, so when we tap on your knee and it's really jumpy, that tells us you might have damage to brain or spinal cord and is usually associated with spasticity. Clonus is a repetitive movement of a joint, so at the wrist like this, and that can also happen at the ankle and tells us that the muscles are spastic. And then in late stages, you can get contractures, where the muscle becomes tight and shortened and actually can stay in that position if we don't do a good job of treating it. When it comes to the treatment, there's lots and lots of different options. And the first thing to know is that just because spasticity is there doesn't necessarily mean it needs to be treated. So we want to talk to you about how it's interfering with your daily life and how it's affecting you, and then that guides whether we treat it and how we treat it. So we're going to start off with these lifestyle things, which we're recommending to almost every single patient who has spasticity. The first thing we can do is talk about triggers. So there's many things that can worsen someone's symptoms, and it's important to identify those triggers because sometimes they can be avoided. So sometimes it's extremes of temperature, like cold temperature or fatigue, or being sick, or emotional stress, constipation, or urinary retention. So some of those things can be avoided. Others, like stress, it's a little harder to avoid. But when we can remove the triggers, that can be helpful. Stretching is really important because the muscle, when it's tight, it gets shortened, and we want to stretch that muscle out to reverse the spasticity. And so stretching exercises are incredibly important, and you want to stretch the specific muscles that are causing you problems. Coming back to exercise, we know that there are multiple different benefits of exercise with MS, but also with spasticity. Doing exercises that can improve motor control, improve strength, and improve functioning of those muscles and limbs. And of course, our physical and occupational therapists are very important when it comes to spasticity management. So almost every single patient we have that we're seeing for spasticity is going to see physical and occupational therapy at some point, because they can really help us to make an exercise program specific for you, help you with stretching exercises, also evaluate you for other things that could be helpful, like a splint that can kind of relax and stretch that muscle that you might wear at night or might wear intermittently throughout the day. So there's also lots of medications that we might consider when treating spasticity. The most common medicine we use is probably oral baclofen, and this is a muscle relaxant that is given 3 times a day. We can start at low doses and work the dose up if we need to. Most commonly, it can cause sedation, confusion, nausea, and dizziness, and usually the side effects are worse at higher doses, which is why we start low. Tizanidine is another muscle relaxer that can be given 3 times a day, has some similar side effects, as well as dry mouth and some liver damage as possible, so we would monitor that. Dantrolene we use less commonly, but it can also cause sedation, weakness, nausea, liver damage. Gabapentin is a medicine we use commonly, but also we're prescribing a lot for neuropathic pain. So nerve type pain that's burning or tingling pain, we commonly use gabapentin for, but also used off-label for spasticity, and has some of those similar side effects we've seen with these other medicines. Benzodiazepines we use very rarely, and we try to avoid when we can because they have more side effects, and they can also lead you to feel dependent on them. In addition, if you're on them long term and you come off of them suddenly, that can cause withdrawal and a lot of risks like seizures. In some cases that are more severe, we do use benzodiazepines like diazepam, Valium, and we just have to look out for some of these side effects and make sure we're not stopping it suddenly. And then I included medical marijuana in here, which can mean a lot of different things, but medical marijuana, it includes different cannabinoids. So cannabinoids are the different chemicals in marijuana, and the most common ones you hear about are CBD and THC. And there have been lots of studies looking at whether these different chemicals can be helpful in treating spasticity. There's one medicine called nabiximols, an oral mucosal spray that's not currently approved in the US, but there's been trials and it's been approved in other countries. And Dr. Nicholas actually just published on this, I found when I was doing my research. But there are some potential benefits when it comes to medical marijuana. The question is, in what form do we use it and what side effects do we need to look out for? Because we know, at least with recreational marijuana, there's lots of risks, especially cognitive side effects long-term, sedation, confusion, anxiety. So with everything we do in medicine, it's about weighing risks and benefits and making sure it's used correctly for the right patient. So in looking at this list, you can see a very common unifying potential side effect is sedation. And this is probably the most common thing we run into. So when someone's requiring lots of medications and they're getting sedated because of these medicines, that's usually when we start thinking about other things like procedures. You don't need to try medicines first to use a procedure, but a lot of times that's the order things happen in. So when it comes to procedures, the first one I want to tell you about is botulinum toxin injections. And this comes in a couple of different forms. So there's Botox and Dysport. And what we do with botulinum toxin is we inject the medicine directly into the muscle that's spastic and causing problems. So this is really good for patients who have spasticity, especially on one side of the body or just in one limb, because we can target those specific muscles without causing all of these side effects to the whole body. So for example here, in this person, they have a tight calf muscle, and it's pushing their foot down, and that's making it hard to stand flat, probably causing pain and discomfort. Maybe they're having to swing their leg around when they're walking so that they don't trip on their toes. So in this patient, we could give the medicine directly to that muscle that's tight and relax the muscle so that it can stretch out, they can stand with their foot flat on the ground, be more comfortable, and probably improve their ability to walk safely. So this medicine lasts for about 12 weeks, the effects of it, and then we would keep doing injections, so you would end up getting it about 4 times per year. Another surgery procedure that we deal with a lot in our spasticity clinic is intrathecal baclofen pumps. So this is a surgery where you actually have a device placed under the skin that has a pump that's filled with baclofen. And it's a very concentrated form of liquid baclofen, the same medicine we talked about before that we use most commonly in pill form. And then attached to this pump is a catheter that travels all the way into the space surrounding the spinal cord. So the medicine's delivered directly to the area surrounding the spinal cord. So it goes to the site of action where we want it to work. So that can be really beneficial because we can use much lower doses and get really good effects, but also avoid some of those side effects that we see with the oral use of baclofen. This is especially helpful in people who have spasticity of both legs or all of their limbs, because that would be someone who it's hard to give botulinum toxin to because there's too many muscles and we wouldn't have enough medicine. The intrathecal baclofen pump is great for people with that type of spasticity that's more generalized. It is important to know that some of the risks of the baclofen pump, we need to avoid the medicine running out. So that medicine or that pump holds a specific amount of medicine, and that pump needs to be refilled at least twice per year. So we only use these pumps in our patients who we know are going to be able to make it to their appointments reliably, because for safety reasons, we need to make sure you don't run out of the medicine. Less commonly, but some patients will need orthopedic surgery for spasticity. So this is when spasticity gets to the point where it's causing contractures. The contractures are when the joint is staying in a fixed position. So in this patient, they had a contracture at the elbow where the arm was staying flexed, and they required surgery to lengthen some of those muscles and tendons to allow the elbow to relax into a more neutral position. It's uncommon that we have to refer people for orthopedic surgeries, but this is just to know if someone does get to the point where they have contractures and these medicines that we have or other procedures we have are no longer helpful, that there are options to help with comfort in these patients. The dorsal rhizotomy, I think, is not really pertinent to this population, but I'll tell you about it anyway because it's another surgery. So this is when it's commonly done in children aged about 2 to 5 who have spasticity, from birth complications, and it's a permanent surgery where nerves are being severed to interrupt that abnormal signal and to prevent the spasticity. So what are our goals of treatment? This is really individualized. So in that first visit where we're talking to you about your spasticity, we're going to ask, how is it affecting your daily life? Is it causing you pain or discomfort? Is it impacting your ability to do your normal daily activities? Is it causing safety concerns? And so it really depends on the specific person what those goals are going to be. In some people, they're going to say, I just want to reduce those painful spasms that are bothering me. In others, they want to be able to walk more safely, and so we're going to be injecting muscles in the leg or treating with certain medicines that can help reduce spasticity in the leg. So it really depends, is the answer here, what the goals of treatment are. And the same goes for what is the best treatment. So we have all of these different options. How do you decide which one to do? The truth is, in almost every patient, we're going to be talking about the lifestyle things, because those are no-risk things that we can do to help, including the stretching, the exercising, avoiding triggers, doing physical and occupational therapy. And then a lot of times it's going to be a combination of other things when we need them. So we're weighing the risks and benefits of a medication option, same with procedures or surgeries. So a lot of times it might end up being a combination of things, and that combination depends on the specific person. So here are my references.